Welcome, everyone, to this 2015 Resuscitation Guidelines update for CPR, Emergency Cardiovascular Care, and First Aid webcast, presented by the Heart and Stroke Foundation. Thank you for joining us. My name is David Sculthorpe, and I am the CEO of the Heart and Stroke Foundation. I'll be your host for today's session. Let me begin by explaining how the webcast will work. Throughout the presentation, you'll hear and see several experts. You will see their presentations on screen. The slides will advance on their own in time with the speaker's presentation, so there's no need to navigate, just follow along. If we do lose our connection during the event, we will pause the presentation for 5 minutes to try and find an easy solution. If we haven't solved it within 5 minutes, please disconnect from the live stream. We will resume the presentation for recording purposes, then share the recording with you later on today by email. The presentations will take about an hour, and we'll use the remaining time for Q&A. And we'll be sure to wrap up on schedule at the bottom of the hour. Send questions via email as they occur to you. The email address is gl2015@hsf.ca. Please indicate the topic area you're asking about in the subject line of the email. For example, if you have a question about BLS or first aid and so on. If we can't get to all the questions, we will add them to our FAQs on the Guidelines 2015 website. Following this English webcast, we will be providing a French language webcast. Both versions will be available on our Guidelines 2015 webcast. We'll show the website address at the end of today's program. You're invited to download and use them or share the links with your colleagues, students, and contacts. I'm very pleased to let you know that we've gathered an incredible cast of Heart and Stroke Foundation ILCOR delegates and senior science experts to walk you through these important science updates. Before we get started, I would just like to explain a bit about the guideline process and the Foundation's role in getting to today. Over a rigorous 5-year process, leading experts from around the globe meet and collaborate in the review of new research and evidence relating to resuscitation and first aid. This group is collectively known as the International Liaison Committee on Resuscitation, or ILCOR, and the Heart and Stroke Foundation is both a founding member and the only Canadian member. The delegates who represent the Heart and Stroke Foundation of Canada at ILCOR are truly the leading international experts. Many of them chair or co-chair ILCOR subcommittees. All are highly respected the world over. These committees look at the science from the perspective of what changes in practice or systems have the most potential to save lives. Where can we have the most impact on improving patient outcomes? Their recommendations are shared worldwide. The next step again involves these Heart and Stroke Foundation delegates who jointly with their American counterparts and the American Heart Association translate ILCOR's recommendations into North American guidelines. All the while, they ensure that the final product considers Canadian health system realities as required by you, our Canadian resuscitation stakeholders, clinicians, and educators. In other words, they are made to measure for use in our country. The Foundation is dedicated to providing you with the best training materials. Our materials are being updated as we speak so that they reflect the changes we will learn about today. The Canadian ILCOR delegates volunteer a tremendous amount of their time over this multi-year process. In fact, 4 of 7 task forces are co-chaired by Canadians. We owe them a deep debt of gratitude. We're extremely fortunate to benefit from their expertise and thank them for their dedication and passion. And we are thrilled to welcome Webcast viewers from across Canada. Getting the word out on the importance of CPR and emergency cardiovascular care and first aid is central to our mission. Ensuring that our instructor network, resuscitation stakeholders, and clinicians are up to date with the most current information is equally important. That's why we are here today. It's now my honor to introduce our first speaker, Dr. Andrew Travers, ILCOR Basic Life Support Task Force Co-Chair and ILCOR Delegate, to speak about the 2015 guideline updates relating to systems of care and basic life support. Dr. Travers.
Thank you, David. Good afternoon, everybody. My name is Andrew Travers, and I hail from Halifax, Nova Scotia. Before I begin, I want to show you a flow diagram, a formula for success, actually, for improving resuscitation within Canada. And that formula is illustrated by the Zutstein diagram, which shows that the medical science that we're going to talk about today, coupled with the educational efficiency that the resuscitation network has in Canada, factored by local implementation, is what improves survival. And this formula, although hard to implement, requires actually some work going forwards to get some consistent definitions about how to achieve these types of goals. To that end, Heart and Stroke has published guidelines on systems of care, and within those guidelines provides new definitions for what makes up a system, as well as new chains of survival for practitioners within Canada, a chain of survival for out of hospital and a chain of survival for in-hospital cardiac arrests. And many of the lessons learned and published in these guidelines have been actually extrapolated from such groups as managing patients with heart attacks or managing patients with stroke and trauma. Some of the definitions which resuscitators need to understand within Canada is what makes up a system of care, the taxonomy. And some of the take-home points is the idea that a system of care has 4 elements to it. Structure elements, which includes people, equipment, and education. Process elements, which include policies, procedures, and protocols, which when combined together make up a true system of care. And when those things are lined up well, we can actually affect effective and safe and quality patient outcomes. And as a key thing, as you see in this diagram, the iterative process and a culture of quality that links up these outcomes to these individual elements is a key factor of success. Another major change in 2015 is the implementation of a new chain of survival for in-hospital cardiac arrests, and in the introduction of some new icons associated with that. You can see on the far left hand of the chain of survival for in-hospital cardiac arrests is a magnifying glass. The idea that in-hospital teams and responders are actually hardwired and trained to watch for patients that may deteriorate on the inpatient floors of a healthcare system. And if that patient does deteriorate or become unwell, that a chain of survival is built for them with early activation, early quality CPR, early defibrillation by the code team, early access to the cath lab. And that leads us to the final bit of icon, effective and quality post-arrest care, which includes both a number of basic post-arrest care items and advanced post-arrest care items. I'd like to switch gears and talk about the basic life support from the perspective of a lay rescuer. There's been a continued re-emphasis in 2015 on the proper sequencing. Again, in 2015, we're recommending that the sequence being compressions, airway, and breathing, or C, A, and B. There's further evidence that also shows the effective compression ventilation ratios remain at 30 and 2. What the guidelines and recommendations now reflect are some of the tools available to lay rescuers, a cell phone and an automatic defibrillator. And the guidelines are very explicit to reflect that rescuers can activate the emergency response system without having to leave the patient's side. And that's a key thing to enable a rapid time to first compressions and defibrillation. The second item is having access to an AED in the community setting. And there's strong recommendations in 2015 that communities at risk for cardiac arrest should implement public access defibrillators. Also recognizing the emerging body of evidence in 2015 is the choreography of care. as a lay rescuer, as a single provider, when accessing and interfacing with 911. There's clear recommendations and support that lay rescuers should immediately and simultaneously recognize unresponsiveness, activate the emergency response system, and provide effective quality CPR. In addition, at that critical moment, the importance of connecting with the 911 operator as they can provide dispatch instructions to that caller to carry them and walk them through how to do chest compressions in case they're unaware of how to do it properly. And that life-saving importance of the pre-arrival instructions, or what we term dispatcher-assisted CPR, is one of the highlights in the 2015 recommendations. And key to enable that is having the dispatchers be able to effectively diagnose a cardiac arrest by focusing on the ascertainment of agonal respirations of the patient through the information provided by the caller. Again, in 2015, for the lay rescuer basic life support provider, is the emphasis on quality CPR. Clear evidence that shows that chest compressions to be provided at an adequate rate and adequate depth, allowing full chest recoil and minimizing interruptions in chest compressions, and all the while avoiding excessive ventilations. I'll return back to this, but it's important for the lay rescuer and basic life support to push hard and to push fast when they're dealing with someone in cardiac arrest. There's also recognizing the evolving burden of risk and injury associated with opioid-associated life-threatening emergencies, having some kind of strategy in very precise situations and precise environments of bystander naloxone use in opioid-associated life-threatening emergencies. It's important for resuscitation stakeholders in Canada to understand that at present, bystander naloxone is still a prescription-only medication available within Canada. And we look forward to working with stakeholders and moving this initiative along across Canada. I would like to switch gears and focus on the healthcare provider basic life support and the emerging and evolving evidence supporting the choreography of care that is provided by the healthcare provider, with a focus on single rescuers, when trained in healthcare circumstances, performing some of the steps simultaneously. For example, checking breathing and a pulse at the same time. The focus on reducing the time to first compressions and the time to first defibrillation. Again, clear evidence, clear guidelines, clear recommendations, clear protocols when there's more than one responder, how they work together in a well-choreographed approach where providers will be simultaneously doing things concurrent to the patient care, as opposed to providing things in a linear sequence as they would if they were a single provider. And that type of information is clearly mapped out in the 2015 guidelines. The challenge for the healthcare provider is that in 2010, we told you exactly what to do in terms of the rate, the depth, the recoil. And it was clear that in 2010, it said at least 100 compressions a minute and onwards. In 2015, though, there's now clarity on the upper limits for each of these. So to be precise, healthcare providers, when providing basic life support, should provide chest compressions at a rate of at least 100 compressions per minute and not to exceed 120 compressions per minute. Healthcare providers' basic life support should push to a depth of at least 5 centimeters, but not beyond 6 centimeters. They should allow full recoil after each chest compression. They should not lean on the chest after each chest compression. Healthcare providers should minimize pauses in compressions, and they should not have delays greater than 10 seconds. And again, for ventilations, they should ventilate adequately, giving 2 breaths between each sets of 30 compressions, each breath over 1 second, causing visible chest rise. They should not provide excessive ventilations, being too fast, too many, or too hard. Now, as a healthcare provider providing basic life support to meet these targets, 100 to 120, between 5 and 6 centimeters, having some element of CPR feedback is important, and the guidelines do reflect that the use of CPR devices could improve the quality of CPR both in the educational realm and clinical realms. For stakeholders, it's important to understand there's insufficient evidence to provide a recommendation on the use of artifact filtering algorithms for ECG analyses during CPR. And finally, some new evidence on ventilations, and if we focus on the out-of-hospital system of care, or EMS agencies. The guidelines clearly reflect the evidence out there where some EMS systems have bundles of therapy where they've delayed ventilations, very precise bundles of care where they're providing airway adjuncts, passive oxygen insufflation, and continuous chest compressions for upwards of 3 chest cycles, which actually showed improved outcomes on patients. And the guidelines reflect that if you have similar types of EMS agencies, that type of protocol can be applied. And also for healthcare providers, when there's an established airway in place, the ventilation recommendations are simplified, recommending that 1 ventilation breath is provided every 6 seconds. Essentially 10 breaths per minute is now recommended to simplify the process for people. Thank you very much for your time and attention.
Thank you, Dr. Travers. I now call on Dr. Stephen Brooks, who is our ILCOR Advanced Life Support Task Force member.
Thank you.
Thank you.
Hello. Very excited to share with you some highlights of recommendations from 3 chapters in the new guidelines. And we'll start with the situation, special circumstances, the situation of cardiac arrest in the setting of a suspected or confirmed toxic ingestion. Intravenous lipid emulsion can act like a mop for lipophilic medications. And although the evidence for benefit is low level, mostly from animal studies and observational studies, intralipid may be considered for the treatment of local anesthetic systemic toxicity, where there's the most evidence, and also there might be a possible role for intralipid as a last-ditch effort in scenarios of cardiac arrest due to toxicity from other types of drugs where conventional ACLS methods are failing. Cardiac arrest in pregnancy is a very challenging situation, of course, because you have 2 patients, the mother and the fetus. The priorities for treating pregnant women with cardiac arrest remain the provision of high-quality CPR, but there are certainly some other considerations. One is the issue of the gravid uterus compressing both the aorta and inferior vena cava to impair venous return and hemodynamics. So when providers find a pregnant woman in cardiac arrest and the fundus is above the umbilicus, suggesting that the pregnancy is at least 20 weeks along, there is an indication to attempt to decompress the aorta and inferior vena cava. And this can be done with a manual left uterine displacement while CPR is ongoing in a supine position. In the past, a left lateral position on tilt has been suggested, but we have recommended this time that supine position might be advantageous to improve the quality of CPR provided. Moving on now to the chapter on alternative techniques and ancillary devices. We first discuss the impedance threshold device. This is a device that's placed on the airway during CPR to augment the pump action of chest compressions. And it does this by limiting the passive inflow of air during the decompression phase of chest compressions. Active compression-decompression CPR is an alternative CPR technique which involves a suction cup-like device placed on the chest, which allows the provider to pull up in the decompression phase of CPR. And the idea is that you improve the efficiency of the chest pump. The ITD has been tested in isolation and also in combination with active compression-decompression CPR. The ITD alone was studied in a large North American randomized controlled trial, and despite the study being very high quality, there was no difference between the ITD and a placebo. Several trials have examined the use of ITD in combination with ACD CPR, and the best evidence that we have demonstrates that there may be a benefit with respect to survival, but there were several concerns with methodology, and as such, the recommendation is not for routine use, but this combined technique can be considered for use in settings where the equipment is available and personnel are trained. Mechanical chest compression devices have been around for decades. These are automated machines that provide compressions with a machine in lieu of conventional manual compressions. Knowing how important CPR quality is, these machines were designed to reduce the effect of provider fatigue and maintain consistent quality throughout a resuscitation. There are different devices on the market which can be divided into piston devices and load distributing band devices. Essentially, piston devices, just how it sounds, a piston on the center of the chest, sometimes with a suction cup that rhythmically compresses the chest. A load distributing band device is a band around the chest with a rigid backboard that lengthens and shortens in a rhythmic fashion to facilitate chest compressions. Most published studies on these devices that compare the devices against conventional manual chest compressions were unable to demonstrate a benefit with mechanical CPR devices, and one study actually demonstrated equivalence between the two techniques. On this basis, we recommend that mechanical devices may be a reasonable alternative to mechanical compressions, and it might certainly make sense, especially in situations where manual chest compressions are either difficult to accomplish with high quality or dangerous, such in situations where there are a limited number of rescuers around, in a moving ambulance, or with prolonged CPR. Moving on now to advanced cardiac life support, we first discuss vasopressors. Epinephrine has been standard in cardiac arrest treatment for a long time. Available data for epinephrine in cardiac arrest is certainly low quality, but the best evidence we have suggests improved return of spontaneous circulation with standard dose epinephrine versus placebo. Data from large observational studies suggest that once you decide that epinephrine is indicated in cardiac arrest, it's best if we give it as soon as possible. So certainly epinephrine hasn't moved up in our algorithms, but if there's an opportunity for multiple providers to be providing parallel treatment with a focus on high quality CPR, perhaps people can start to get the IV at the same time as starting resuscitation and deliver the epinephrine as soon as feasible in the given scenario. Vasopressin has been removed from the adult ACLS algorithm. New evidence since 2010 adds to older evidence suggesting no advantage of vasopressin alone or in combination with epinephrine. End-tidal CO2 is recommended as a modality to monitor various aspects of a resuscitation. This guideline here suggests that end-tidal CO2 can be used to support decisions around when to cease resuscitation, deciding when resuscitation is futile. Specifically, in intubated patients, failure to achieve an end-tidal CO2 of greater than 10 millimeters of mercury after 20 minutes of CPR can be considered as one component of a multimodal assessment of whether to stop. Other items might include the response to resuscitation, comorbidities, and perhaps ultrasound evaluation of cardiac activity. Extracorporeal CPR, so this is the use of ECMO circuit or cardiopulmonary bypass for the treatment of cardiac arrest. There have been some exciting developments in the literature since the 2010 guidelines, and so we examined this question. eCPR, or the use of cardiopulmonary bypass during cardiac arrest, can be used as a bridge therapy when the cause of cardiac arrest is suspected or confirmed to be reversible. So based on large observational studies, mostly from Asia, we recommend that it may be considered among very select patients who fail to respond to conventional CPR. Steroids have been tested in almost every other condition, so now it's time for us to consider it in cardiac arrest. Based on the results from 2 RCTs of in-hospital cardiac arrest patients, mostly from one center, methylprednisolone bundled with epinephrine and vasopressin during in-hospital cardiac arrest is not recommended for use but may be considered. These studies suggest potential benefit with respect to a survival outcome, but the studies are small, have some methods issues, and again, we're mostly from one center. There's no data for out-of-hospital cardiac arrest patients, so the benefit of this bundled therapy is uncertain. Switching now to look at the prevention of arrhythmias in the post-arrest patients or the immediately resuscitated patient. There's always been uncertainty about whether there's anything that we can do to prevent recurrent cardiac arrest in these patients. The best available evidence that we have from mostly observational studies suggests that lidocaine may reduce recurrent arrhythmias, but does not indicate a survival benefit. Therefore, the evidence isn't strong enough to recommend routine use, but it can be considered in specific situations where a patient has achieved pulses after a shockable cardiac arrest. Similarly with beta blockers are known to reduce the potential for arrhythmia, but can also impair hemodynamics. Best evidence that we have from observational studies don't provide enough evidence to recommend it routinely, but again, they can be considered for patients surviving to hospital admission. Thank you.
Thank you, Dr. Brooks. Please join me in welcoming Dr. Michelle Welsford, who is our ILCOR Acute Coronary Syndromes Myocardial Infarction Task Force member.
Thank you. Wow. I'm pleased to speak on behalf of the many Canadians who were involved in these guidelines and would like to take a moment to celebrate the survival, the improved survival from cardiac arrest over the last decade that is really the result of these previous guidelines and focusing on those items that can lead to improved survival and save lives. So, let's talk a little bit about post-resuscitation care, and there's three main things that we can focus on early and post-arrest care to optimize neurologically intact survival. The first is consideration for angiography and PCI. The second is targeted temperature management, and the third is hemodynamic support. So the 2015 guidelines put further and greater emphasis, really, on emergency angiography post-arrest and recommends that all patients with presumed cardiac etiology be considered for emergency coronary angiography. Those with ST elevation likely have the greatest benefit, and thus there's a stronger recommendation. However, selected patients without ST elevation may also benefit and should be considered. So let's talk about targeted temperature management. Previously referred to as therapeutic hypothermia, targeted temperature management is strongly recommended and is now expanded to all arrest rhythms. The duration of 24 hours is new. The new evidence also suggests that the target temperature fall between 32 and 36 degrees. And this comes from new evidence that compared 32 to 36 degrees and has found that both are beneficial. The most important thing is that we avoid fever and that you do intentionally keep the patient within a certain temperature range. The routine pre-hospital cooling of patients, although it's been shown to be feasible, has not been shown to be beneficial. And therefore, in order to minimize the complications and or the complexity of care, we want paramedics rather to focus on the variety of other tasks that they're focusing on pre-hospital care, and we do not recommend routine pre-hospital cooling of patients. And so the third was hemodynamics. Certainly we need to avoid and correct hypotension in the early and immediate post-arrest period. The targets are a little bit unclear, but certainly we need to aim for a mean arterial pressure of 65 millimeters of mercury or greater, or a systolic blood pressure of 90 millimeters or greater. And certainly, I'd also like to emphasize that when resuscitation may ultimately not be successful, many lives can still be saved through organ donation, and this should be considered. So let's talk about acute coronary syndromes as well. Certainly the acute coronary syndrome section this time focused on pre-hospital care and early emergency department care and really looked at the systems of care for ST elevation MI patients and ACS. We have confirmed again that the pre-hospital ECG interpretation for STEMI patients coupled with hospital activation saves lives. ECG STEMI interpretation by paramedics can certainly be accurately done and should not and can be used with as an adjunct to computer interpretation, but it's important to recognize that the computer interpretation should not be utilized alone. There are two main reperfusion strategies for STEMI patients or ST elevation MI patients. You have fibrinolysis and primary PCI. Primary PCI has really been the preferred option for likely 15 years because of the modest improved outcomes that can be realized, certainly when it's timely. Now, fibrinolysis, which is the standard for decades, still offers very good outcomes. So there are two main frameworks for deciding when fibrinolysis might be appropriate compared to the more preferred primary PCI. The first framework considers the patient factors, such as their length of symptoms when they present to a healthcare practitioner. So those with symptoms of only 1 or 2 hours may benefit the most from fibrinolysis because it's timely, and PCI would be appropriate if it was immediately available. However, those that present late beyond 6 hours would primarily benefit from PCI even when a delay were to occur up to 2 hours. So therefore, what about that group in the middle, the patients who present in the 3 to 6 hour group? And that's where we can talk about the second framework. The second framework considers the regional system and the availability of pre-hospital fibrinolysis, the availability of PCI centers. And it allows you to have guidance, for instance, on when a patient presents to a non-PCI hospital. So in that non-PCI facility, it's certainly possible to facilitate rapid transport to a PCI facility such that primary PCI can be accomplished. And typically we think of a door in and door out time at the non-PCI facility with a goal of 30 minutes. Additionally, the time from their first arrival at a healthcare practitioner to the balloon time is typically thought of 90 to 120 minutes within this group of presenters. It's important to realize, though, that within the guidelines that certainly when you're developing your system of care, that rapid fibrinolysis in that non-PCI center and then subsequent routine transport for angiography at 3 to 6 hours is also a very good option and is considered appropriate. So now let's turn our attention to something a little bit different, which is looking at the patient that might potentially have an acute coronary syndrome in the emergency department and trying to determine who is safe to discharge from the emergency department. So troponins alone or with unstructured risk assessments may result in unacceptably high outcomes in the next 30 days in terms of complications. So therefore, we've reviewed and found evidence of the use of high sensitivity troponin I at 0 and 2 hours, coupled with a very structured low-risk stratification to identify those people who are at such low risk of subsequent complications that they could potentially be discharged from the emergency department with an outpatient workup. That high-sensitivity troponin I evidence, unfortunately, was not also found with the marker high-sensitivity troponin T, and so we'll need subsequent evidence in the future to determine its use. However, the traditional type of troponin, non-high sensitivity, troponin I and troponin T, can be used at 0 and 6 hours with a structured, very low-risk stratification tool to identify those people who could potentially be discharged from the emergency department. These rules you will find in the literature, such as the Vancouver Rule, the North American Chest Pain Rule, and the HEART score. So there's a couple last items that I just wanted to talk about, the first being oxygen. Okay, so with additional evidence of a new randomized control trial in 2015, really we've confirmed the evidence. We've confirmed that there does not appear to be a role for oxygen administration in the patient with ACS or with STEMI, unless specifically they're hypoxic. So therefore, the recommendation is to withhold routine oxygenation in ACS and STEMI patients if their oxygen saturation is normal. predominantly for those that are greater than 92% or above. And then lastly, we reviewed a number of pre-hospital medications and looked at the evidence for use for them for ACS patients. So if a medication has proven benefit in hospital, it may also have a benefit when given pre-hospital, and giving it earlier may in fact be better. However, sometimes there's no additional benefit, and the complexity of administering additional medications needs to be an important consideration. So therefore, ASA administration is still supported. However, due to a lack of evidence of benefit and the concern about complexity, there is not a recommendation to start pre-hospital medications such as ADP inhibitors, medications such as clopidogrel and ticagrelor, or anticoagulants such as heparin. So they are not recommended at this time to be started in the pre-hospital field. So thank you very much.
Thanks, Dr. Welsford. I just wanted to quickly note that we've been receiving some great questions. Please remember that we will be conducting a Q&A following the session of formal presentations. If you have questions, please email it to us at the email on the screen, gl2015@hsf.ca, and indicate your topic area in your subject line. We'll do our best to answer as many questions as possible as part of the webcast. Next up is Dr. Alan DeCon, who represents the Foundation as our ILCOR Pediatric Life Support Co-Chair and ILCOR Delegate. Alan?
Thank you, David. So, my name is Alan DeCon. I'm a heart and stroke volunteer from Stollery Children's Hospital in Edmonton. And what I'm going to speak to you today about is the changes in both the basic life support guidelines for children as well as the advanced life support guidelines for children. So I guess we'll start off with speaking to the basic life support guidelines. Now, we're in a better place now than we were 5 years ago, in that there are a lot of new studies, high-quality studies, that have actually been carried out in children in resuscitation science and cardiac arrest science. But we are still dependent upon a lot of extrapolation from adult science as well. So I'm going to repeat a few of the recommendations that Dr. Travers made earlier that also apply to pediatrics. In regards the metrics of CPR, and clearly this is for, especially for basic life support, this is not supposed to replace the emphasis upon pressing hard and pressing fast, but especially for healthcare providers that do have the ability to measure CPR metrics, making sure that we have an upper limit of chest compression depth of 6 centimeters, so that we don't end up running into potential complications of excessive compression. In regards chest compression rate, once again, extrapolating from adult data, there is a suggestion that chest compression rates of greater than 120 compressions per minute may be associated with worse outcomes. So for children, we recommend compressing at a rate of between 100 and 120 chest compressions per minute. Although chest compressions are very important, especially in pediatric cardiac arrest, which tends to be asphyxial in nature, we do end up emphasizing the importance of ventilation as part of good CPR, but we do not want to de-emphasize the importance of, if everything else fails and ventilations cannot be given, then at least provide high-quality chest compressions, at least press on the chest. And as I alluded to earlier, I think now that we are in the world and moving towards a world of not just providing high-quality CPR, but measuring it to ensure that we're actually achieving those targets, we are recommending that where available, CPR feedback devices should be used by healthcare professionals so as to ensure the provision of high-quality CPR. The CAB sequence that Dr. Travers spoke to still applies to single rescuer CPR for children. Although once again, I think when we're speaking about resuscitation in the in-hospital setting with multiple rescuers, it becomes this very much synchronized approach of parallel resuscitation as opposed to taking things in a sequence of CAB. So it's the same recommendation as what Dr. Travers made in adult CPR. As well as what Dr. Travers alluded to, now the recognition that timely activation of an emergency response system by lay rescuers using cell phones is equally important in pediatric CPR as it is in adult CPR. What I'm going to do now is I'm going to move on to highlight some of the changes in pediatric advanced life support that we've made in the last 5 years. The first one is in regards to fluid resuscitation for pediatric septic shock or severe sepsis. For many years, we've emphasized the importance of the use of often aggressive fluid resuscitation regimes to manage shock states in children. And I think what's happening now is we have an increasing awareness that fluid is just like any other medication. There is a right dose to give for an individual patient. So I think our challenge ends up being in pediatric septic shock is trying to identify what that right dose ends up being. So this is not to say that we are de-emphasizing the importance of fluid as part of pediatric shock management, but the reality is that what we need to do is we need to frequently reassess the patient both during as well as after fluid boluses. Using our standard approach historically that we've given of 20 cc's or 20 milliliters per kilogram for bolus dosing is still appropriate, but we need to be cautious, frequent reassessment, and especially if we are working in a setting where there may be limitations in terms of resources and timely access to assisted ventilation or to inotropic support, then increased caution when it comes to how we use fluid as part of pediatric septic shock resuscitation. Atropine has been used as a part of rapid sequence intubation medication regimes for many, many years. And clearly what we have now that we didn't have 5 years ago is better data. It is still, it's retrospective data, it's not prospective, but at least it's better data than we had to give us a suggestion as to what its best role might be. Clearly, what the data suggests is that there is not an indication for routine usage, but in situations where where there is an increased potential for bradycardia, examples might be the concurrent use of opioids such as fentanyl or succinylcholine, then the use of atropine as part of an RSI may be appropriate. Once again, this comes out of data over the last 2 years that actually suggests a mortality benefit, reduced mortality rate in the use of atropine for children undergoing emergent intubation. The other change compared to 5 years ago is for decades we've actually spoken to a minimum dose of atropine when we're using it for rapid sequence intubation. That minimum dose has now been removed. The standard dose that's to be used of atropine, if it is going to be used as part of RSI, is 0.02 milligrams per kilogram per dose. The part of the basic foundation of advanced life support for children in the setting of cardiac arrest does end up being a foundation of high-quality CPR, and this is not just in the BLS world; it's equally important in the ALS world. The difference in the ALS world is often we have ways of measuring CPR quality which are unique. End-tidal CO2 was spoken to earlier in the adult guidelines, and we do end up suggesting that if you end up having access to end-tidal CO2 monitoring during cardiac arrest, that you do monitor end-tidal CO2 to give an indication as to high-quality CPR, striving for an end-tidal CO2 of at least greater than 10. If the patient is invasively monitored with arterial lines, then clearly we can also, at least qualitatively, strive to provide better CPR quality by actually titrating chest compressions to arterial line monitoring. When it comes to actual evidence to show what the numbers we should be striving for, unfortunately we still don't have those, but still qualitatively it makes sense, and the guidelines are advising that if you have it, feel free to use it. For shockable rhythms in pediatric cardiac arrest, specifically ventricular fibrillation and pulseless ventricular tachycardia, for many years now we've advocated the use of amiodarone as a drug for drug use during those resuscitations. Some research that's come out over the last few years, which is it's retrospective data, but still out of large pediatric cardiac arrest registries, suggests that either amiodarone or lidocaine are reasonable alternatives for drugs support for those scenarios. And finally, extracorporeal CPR. You heard about this spoken to as part of adult ALS. And clearly within pediatrics, there is increasing data that suggests that it is an option for children that have cardiac disease and are in cardiac arrest in an in-hospital setting. And what we're emphasizing, though, is that really if it's going to be used, it should be used in settings where you have the appropriate expertise, personnel, and equipment to provide that kind of technology support appropriately. Finally, going to emphasize that for those children that we do end up managing to resuscitate, the emphasis post-resuscitation needs to be upon optimizing outcomes and optimizing specifically neurologic outcome. So I'm going to speak to 4 points that are embedded within the guidelines to speak to that. First one is temperature-targeted management for infants and children after cardiac arrest that remain comatose. We now end up having good prospective randomized controlled trials that actually tell us that continuous monitoring of core temperature is critical if we're going to manage these patients and optimize their outcomes. This is the possible strategies they can use are to either strive for a temperature between 32 and 34 degrees Celsius, or to strive for a temperature between 36 and 37.5 degrees. But the main point embedded within both of these strategies ends up being to avoid fever. And basically, that avoidance of fever is important for that first 5 days after cardiac arrest, so as to improve neurologic outcome. We end up knowing that the post-resuscitation hypotension and shock is common after resuscitation in infants and children, and we actually have good retrospective data now to show that avoidance of hypotension with the use of fluids and inotropes makes sense and appears to be associated with improved outcomes. So it is important to monitor blood pressure as well as to avoid hypotension after cardiac arrest, after resuscitation from cardiac arrest in infants and children. There is suggestion from animal data, as well as some adult data, that hyperoxemia may be associated with worsened outcomes after cardiac arrest. And we continue to stress that if the patient saturation, when the patient saturation is being monitored, if it is running at 100%, we titrate the oxygen down. So we want to keep the FiO2 low enough so that the saturations are less than 100%. But even worse than hyperoxemia is hypoxemia, so a low oxygen saturation after cardiac arrest. So clearly, of even greater importance than avoiding the saturation of 100% is making sure that our patient oxygen saturations are at least 94%. And finally, we know that extremes of arterial CO2 levels in infants and children after resuscitation are associated with worsened outcomes. The current guidelines suggest to avoid hypocapnia and hypercapnia in infants and children after resuscitation, but we also recognize that dependent upon the underlying disease state that an infant or child has prior to the arrest, that the norm that we're looking at, that we're targeting in that infant and child may be different between individual children. So once again, avoidance of hypocapnia and hypercapnia. Thank you very much.
Thank you, Dr. DeCon. Our next presenter is Dr. Farhan Banshi, who represents the foundation as ILCOR Education, Implementation, and Teams Force Co-Chair and ILCOR Delegate. Dr. Banshi.
Thank you very much. I'm excited to share some interesting new guidelines that were developed by a lot of people that spent hundreds of hours, including some very dedicated Canadians. And I'll just try to present a summary of what we've put into the guidelines. First and foremost, I think it's important to take a look at how we teach CPR and how what we're teaching may not actually result in the outcomes that we want from the learners. So we know that instructors are not great at being able to tell the quality of CPR that someone's performing. We think we might be able to, but much like the person that's trying to feel a pulse, a lay provider, a pulse in a panic situation, we can't really tell how good that CPR is. Providers themselves, the people that are learning in those courses, also have difficulty in their ability to tell how good their compressions are. So where does that leave us? That leaves us with a situation where we want to help them to learn and be able to do their CPR better. We know that some of the bad habits that people pick up within the courses actually stay with them. So if you run 5 cycles of CPR, or if you're supposed to run 5 cycles of CPR, but you train somebody with 3, what they remember afterwards, if you test them again, is that they remember that 3, and that's what they actually do. So we don't want them picking up bad habits while they're training. So one of the things that we've actually recommended is to use a CPR feedback device to guide people and help them figure out the right depth, the right rate, the right way to allow for full recoil, and to keep their chest compression fraction up. And that's going to be a critical next step to getting people trained in doing high quality CPR. And it's something that we should be implementing both as we're training skills in CPR courses, in resuscitation courses in general, but also as we run scenarios in advanced life support courses. For those of you that are instructors out there, you know that as you're watching teams perform and as they're thinking about the higher order skills of working as a team, of getting the medications, of thinking about defibrillation, sometimes what's lost is the CPR performance of the people that are on the chest. And we need to focus them and get them to do good quality CPR throughout the training so that they don't learn bad habits as they get out into practice. High fidelity mannequins. So high fidelity mannequins have been around for a little bit of time now. We define them as those that can give you the sense of realism from the patient end. So they are mannequins that can breathe, they have a pulse, they can have a chest rise, they have vital signs. Those vital signs can respond to medical interventions when there's an operator that works at a machine to change those vital signs on the fly or with a pre-programmed script. So what we are suggesting is that to use those high fidelity mannequins in centers, in programs that actually have the infrastructure to apply them. We know that if you use those high fidelity mannequins, the learners end up learning better. Now that's been done in a meta-analysis at the end of training, but they do learn better. And if you have the infrastructure and the trained personnel to use them, then you should be using them. If you're like most people and you don't actually have those high fidelity mannequins, standard mannequins are completely appropriate and still something that people can use. We'd like people to get into that mindset of, as Vince Lombardi says, it's not practice that makes perfect, it's perfect practice that makes perfect. So we'd like them to get into the situation where they're practicing realistically and that they're practicing to do the things that they really need to do to make the difference in patient care. Not everybody's going to have a CPR feedback device. They're not that expensive anymore. There's multiple different brands that make them, and they really should be an investment that we're pushing people towards. But in the short term, if people don't have a CPR feedback device, a tonal device like a metronome or or music can actually be helpful to get people to get to the right rate. Now you have to keep in mind, you're not actually measuring their depth, you're not measuring the recoil or the lean, the residual lean that they have, and you may actually be getting them to pick up some bad habits, and you may want to think about going towards a CPR feedback device. But in the short term, that might be a reasonable alternative. So CPR training. Why do we focus on this? Well, if you really think about it, what stops people from performing CPR? So you think about the number of cardiac arrests in Canada, roughly 40,000. North America wide, we're probably talking around 400,000 people. And what stops lay providers from acting? It's usually fear of hurting the individual. It is panic because they don't know what to do and they're just overwhelmed. It's not so often that fear of catching something, because remember, most of these arrests are actually happening in the home. It's the healthcare provider that actually thinks about or is worried about catching something from doing CPR. But if you note that most arrests are in the house, you're going to be doing this CPR, unfortunately, on somebody that you love. And yet we know that the bystander CPR rates in Canada are roughly only about 30%. So only 1 in 3 people that need CPR actually gets it, when we know that bystander CPR doubles to triples survival. So we want to get more people to do it. You don't need to be trained to do CPR. You need to get your hands on the chest, push hard, push fast. Get the help from dispatch assisted, and that would be something that you can, that everybody should be able to do. For those that want help in overcoming some of that fear and that panic and to be ready for the moment, CPR courses can help. And that's something that we're promoting, that people actually do that. Now, it doesn't matter if you go out and take a long 4-hour course if you're a lay public member, or if you just take a 30-minute, 20-minute video that lets you practice as you're watching or practice after you're watching. Those skills are still learned in that circumstance. And there's many kits out there like CPR Anytime from the Heart and Stroke Foundation that you can actually look at, that you can share amongst family members, and it's really not that expensive. Another important thing to keep in mind is that AEDs do not require formal training before somebody can use them. Simple, they can follow the instructions, and they can do it. Training helps, but it's not absolutely required. In training for AEDs, one of the ways that we may actually offload instructor resources is to have part of that training done ahead of time using computer-based modules, video, that sort of thing, and use a blended learning format so that when they come to the class, they're actually better prepared. And that probably applies to all the courses that we're giving, but that wasn't looked at specifically in the guidelines. Finally, I think we all kind of know this. There's an expression in English that if you don't use it, you lose it. And CPR is no different than that. If you're not somebody that's doing CPR often, if you're not somebody that's measuring the quality of your CPR and getting feedback on that, over time your skills deteriorate. And yet currently, when you take a course, that card is valid for 2 years after that course, or 1 year when you're in other jurisdictions in the world, but generally around that 1 to 2 year time period. We know that more frequent, shorter training actually helps people retain their CPR skills and resuscitation skills better than if you do a bolus training all at once. So there's some interesting work coming out of the Children's Hospital of Philadelphia. Kurosawa and colleagues looked at refresher training in pediatric advanced life support. And what they found was that if you did shorter refresher training time periods than a big bolus of refresher training, that you actually could have better learning or better retention of skills. In the US, when they've implemented this for basic life support, healthcare systems are saving tremendous amount of money because they're not taking people out of the work environment to take their refreshers. So it's saving a lot of money. Even in the early learning phase of a CPR course, there's been some preliminary work done by Catherine Patoka at Calgary in Canada that's looked at the spacing of CPR training for an advanced resuscitation course that has at least the same learning outcomes, if not slightly better, from doing that spaced time period. And what they find is that the learners are actually have a preference to having that spaced format. So those are the key things that we're talking about in terms of education, and I'll turn it back to our moderator.
Thank you. Thanks, Dr. Banshee. Our final speaker before the Q&A session is Jan Jensen, who represents the foundation as our ILCOR First Aid Task Force member. Jan?
Thank you. My name's Jan Jensen, as you've heard, and I'm from Halifax, and I'm pleased to present to you the highlights from the First Aid Guidelines. First, it's important to note that the Canadian Guidelines Consensus Task Force is a group that's going to be brought together, including these organizations: the Heart and Stroke Foundation of Canada, the Red Cross, St. John Ambulance, the Life Saving Society, and the Canadian Ski Patrol. They'll be meeting to further interpret and contextualize these recommendations for specific first aid settings in Canada. These guidelines I'll present to you now are general first aid guidelines. For 2015, we looked at and redefined the definition of first aid, which is the helping behaviors and initial care provided for acute illness or injury. The goals of a first aid provider are to preserve life, alleviate suffering, prevent further injury or illness, and promote recovery. First aid can be initiated by anyone in any situation, and it also includes self-care. For the first time, the evidence for training for first aid was reviewed, and it was found to be effective to reduce morbidity and mortality, and therefore is recommended to be universally available. I'm now going to present the highlights of the key 2015 recommendations, starting with positioning of ill and injured persons. If a person is uninjured but unresponsive and breathing normally, the lateral side-lying recovery position may be reasonable. Other positions are unlikely to be more effective. If the person's unresponsive and not breathing normally, BLS guidelines are to be followed. If the person is injured and that injury suggests a potential neck, back, hip, or pelvic injury, that person should not be rolled onto their side and instead leave in the position found. If leaving in that position causes their airway to be blocked or that location is unsafe, move them only as needed. If the person's in shock with no injury, such as someone who has a simple fainting, shock from a non-traumatic bleed, sepsis, or dehydration, it's reasonable to place that person supine, and you may consider raising their feet if there's no evidence of trauma or injury. And finally, as I mentioned, if the person's in a location that's safe or their airway's blocked, they can be moved as needed. For oxygen administration in these guidelines is generally not considered a first aid skill. Oxygen may be available in some first aid settings. It does require training for use. No evidence was found for or against the routine administration of oxygen by first aid providers. You will see in the guidelines 3 specific indications where oxygen may be used by first aiders who have the training. It may be beneficial for divers with decompression sickness. It may be used for advanced cancer patients who have dyspnea and hypoxemia and oxygen at home. And it may be used for persons who are exposed to carbon monoxide poisoning. A new topic for review for 2015 and an exciting recommendation is the use of stroke assessment systems by first aid providers. There is a significant increase in the recognition of stroke by those who have training, and that persists after 3 months. So therefore, the use of stroke assessment systems by first aid providers is recommended. The simplest of these includes scales such as FAST, the Face, Arm, Speech Test, which you may be familiar with from public campaigns, and the Cincinnati Pre-Hospital Stroke Scale. For first aid providers who have glucose measuring as part of their first aid program, scales such as the Los Angeles Pre-Hospital Stroke Scale may have increased specificity for detecting stroke. For chest pain, if a person may have cardiac chest pain, it is recommended for first aid providers to encourage or assist with the person to take aspirin if they have no allergy or contraindications such as recent bleeding. The suggested dose is 1 adult 325 milligram tablet or 2 to 4 low-dose baby aspirins chewed and swallowed. The first aid provider should call 911 immediately. If the first aid provider feels the chest pain is not cardiac or they're unsure about giving aspirin, they should not administer it and wait for EMS. For allergic reactions, most allergic reactions do not require epinephrine. However, a small portion do progress to anaphylaxis. Those persons who are at risk for anaphylaxis often will carry epinephrine auto-injectors. First aid providers may assist persons in administering their own epinephrine. The recommended dose is 0.3 milligrams intramuscular. The first aid provider should call 911, and if there's no response to the initial dose and the arrival of EMS is expected to be over 10 minutes, a repeat dose may be considered. For hypoglycemia, which also was a new topic reviewed for 2015, if a person with diabetes reports that they have low blood sugar, or they display signs and symptoms of mild hypoglycemia and are able to follow simple commands and swallow, the first aid provider may give oral glucose. Glucose tablets are found to be the most effective than other dietary sugars, but if those aren't available, other things may be used, such as candies like Mentos or Skittles or jelly beans, orange juice, fruit leathers, or whole milk. If the person's status deteriorates or doesn't improve, EMS should be called. And if the person is unconscious, seizing, or unable to follow simple commands or swallow safety, the first aid provider should call EMS immediately. The terms spinal immobilization and spinal motion restriction have previously been used interchangeably. Spinal motion restriction is the preferred term, and it means maintaining anatomical alignment and minimizing gross movement. The evidence review for 2015 was focused on cervical spinal motion restriction. There's a growing body of evidence that there may be some harm and little evidence of benefit with cervical spinal motion restriction. So the recommendation is against routine use of cervical collars by first aid providers. If a first aid provider suspects spinal injury, he or she should have the person remain as still as possible, and that can be accomplished with verbal coaching or manual stabilization until the arrival of EMS. Concussion was also a new topic for 2015. The recognition of concussion can be difficult. Any person with a head injury that has resulted in a change in level of consciousness or has progression in signs of symptoms such as headache or dizziness or unsteadiness should be evaluated by a healthcare professional or EMS as soon as possible. Driving, using machinery, cycling, or continuing in a sports activity after a head injury needs to be deferred until after assessment by a healthcare professional and clearance is obtained to participate in those activities again. No studies were found of a concussion assessment system that could be used by first aid providers. So please note that it's difficult to rule concussion out. And finally, bleeding control remains an important first aid skill. The evidence reviews included pressure points, elevation, the local application of ice, tourniquets, and hemostatic dressings. The control of open bleeding with direct pressure remains the standard approach for first aid providers. Local cold therapy may also be helpful for closed bleeding, such as an extremity or a scalp. In addition to direct pressure, for severe or life-threatening bleeding, hemostatic dressings and tourniquets may be used. First aid providers require the training and the equipment to use these interventions. For tourniquets, the rate of complications has been found to be low, and the rate of hemostasis, or stopping bleeding, is high. And for hemostatic dressings, similarly, the rate of adverse events has been found to be lower with newer generation dressings, and they do appear to be effective. Again, these require training and the proper equipment. These are the main highlights for the 2015 First Aid Guidelines. Thank you.
Thank you, Ms. Jensen. Now we move into the Q&A portion of the webcast. I'd like to remind you that we won't be able to answer every question. So please don't be discouraged if we don't answer you during the webcast. We still welcome your questions at the email address that's on the screen now, which is gl2015@hsf.ca. And we will post a follow-up document on our Guidelines 2015 website. The address will be on the screen at the end of the webcast. I now turn things over to our Q&A team.
The first question that's come in is for Dr. DeCon. Dr. DeCon, in an unwitnessed situation involving a child or infant cardiac arrest where the rescuer is alone, should we call 911 right away with a cell phone, or should we do 5 cycles of high-quality CPR before calling 911 without leaving the child or infant?
Thanks very much, Andrew, for the question. This is still based upon consensus of experts as opposed to great science, just to put that in perspective. So right now we do end up saying for the infant or child that it has a witnessed arrest, then immediate call with a cell phone is appropriate. For the unwitnessed collapse, the unwitnessed arrest, yes, doing a cycle of full CPR before the call goes through using a cell phone is appropriate. So basically, it's still that difference between witnessed and unwitnessed arrest. Unwitnessed, do a cycle of CPR first before using your cell phone.
Great, thank you. Dr. Banji, this question is for you. Do you recommend feedback devices only for training?
So that's a great question. Thanks very much, Andrew. I think that the question around feedback devices, the literature was looked at in multiple different ways. So different task forces at ILCOR looked at it. There was one group looking at it in training, another group looking at it in practice, and yet another group looking at it as a part of a quality improvement process. And I think what we realize is that by using it for training, we can get people trained to a better level. When we can use it in practice, we may be able to get them to perform better. But another key component of using it in practice is to get information into a continuous quality improvement cycle that can actually help to improve the quality of your CPR later on and can help future patients and can help save more lives. And I think that's a critical element of it. So I think the CPR feedback devices are great to use in training, but we should be using them in practice as well and as part of a continuous quality improvement process. If you don't measure, you can't improve. And we need to find better ways of measuring how we're doing so that we can try to do better.
Great, thank you, Dr. Banji. The next question is for Dr. Travers. Dr. Travers, is the maximum depth of 6 centimeters sufficient if the patient's weight is in excess of 300 to 400 pounds?
Again, thank you for this question. I think it raises a very interesting point about patients which would be obese or morbidly obese. And that itself, there's some recommendations in the guidelines about the complexities of managing these ones. The depth of 6 centimeters probably is, again, very difficult to gauge in that size of a patient. And the key thing is making sure that you're achieving at least 5 centimeters of compression. I think the issue with regards to the variations in Canadians in their body size is that these recommendations are based on an average size Canadian. And the only recommendations we can provide from an expert consensus level is that in those circumstances when people are massively obese, that the complexities of resuscitation are spread across the quality CPR, the airway management, the ventilation, the vascular access, etc. So it's do what best you can. The biggest thing for stakeholders is not pushing deep enough, achieving that 5 centimeter threshold. Thank you.
Great, thank you very much. I believe the next question is for Dr. Welsford. Dr. Welsford, for timing of troponin, what is the benchmark for time 0? Is it 0 and 3 to 6 hours from onset of chest pain, worst onset of chest pain, or presentation to the emergency department?
Okay, excellent question. So the time 0 is at the time they present to the emergency department. And so it's at that time that you would draw your first set of biomarkers, and then the time interval of 2 hours later for high sensitivity troponin I, or 3 to 6 hour for non-high sensitivity troponin I or T would then follow. So time 0 is the arrival at the emergency department or the first time you do the tests, and then the interval is between tests. Thank you.
Great, thank you very much. The next question is for Dr. Brooks. Dr. Brooks, should epinephrine be given after 2 shocks or given as soon as you get access?
Thank you for that question. So based on the best evidence that we have from large observational studies, epinephrine, once a decision has been made to give it, it should be given as soon as possible. Studies that were done looking at this looked at large cohorts of patients, and there was an association seen between the time from cardiac arrest resuscitation onset to epinephrine and outcomes, with the longer delays to epinephrine being associated with worse outcomes. So based on that, the algorithms haven't changed in that epinephrine is still deprioritized in comparison to initiating immediate high-quality CPR and, of course, defibrillation in shockable cardiac arrest rhythms. But if, and that certainly would be the priority with a limited number of rescuers, but in the scenario where there are multiple rescuers and the team has the ability to obtain intravenous access in parallel with beginning these other high-priority items, then epinephrine should be delivered as soon as access is achieved.
Great, thank you very much. The next question is from Ms. Jansen. I noticed in the highlights publication there was information on tooth avulsions, but you did not mention this on the webcast. What is the recommendation?
I'm pleased that that question came forward. Tooth avulsions was a new topic for 2015, and the recommendation is something that first aid providers could potentially make a big difference for a person who's suffered from a tooth avulsion. Time is of the essence for someone who has a tooth avulsion. The recommendation is for first aid providers to assist the person to put the tooth into a solution and then seek quick medical assistance or evaluation for reimplantation. Some of the solutions that are recommended for a tooth to be put into for transport for medical help is Hank's balanced salt solution, coconut water, milk. And if none of these or the others that will be listed in the guidelines are available, this first aid provider can help the person put the tooth into the person's saliva, but not in their mouth, of course. So this is an area where first aid provider could potentially make a big difference.
Great, thank you very much. The next question is for Dr. Welsford. It was stated that in the ACS section that pre-hospital Plavix, enoxaparin, heparin are not recommended. What about pre-hospital fibrinolytics in an ST elevation myocardial infarction?
Excellent. So that allows me to go through a bit more detail. So whoever I paid to ask that question, that was awesome. Thank you very much. And I'll owe you later. So when we talk about ADP inhibitors, which are platelet inhibitors, non-aspirin, such as clopidogrel, that you're asking about, certainly those actually have a role when you're doing pre-hospital fibrinolysis. And so it's a complex system, but it occurs in Canada. So we have wonderful systems that can already give pre-hospital fibrinolytics, and along with those, you would also give the ADP inhibitors like clopidogrel and the heparin medications such as enoxaparin, and you give those in combination. What I was referring to was when pre-hospital fibrinolysis is not going to occur, but you're taking the patient direct to either PCI or to in-hospital fibrinolysis. In those systems, there doesn't seem to be a benefit of starting either heparins or ADP inhibitors ahead of time, and therefore, rather than adding that complexity, that those would not be recommended at this time. So thank you.
Great, thank you very much. The next question is for Dr. Banji. Dr. Banji, what is the recommendation for teaching and measuring max depth of 6 centimeters for chest compressions without the use of special mannequins or devices that measure depth of chest compression?
So that's a great question, Andrew. I think that the caller or the person that's writing in that question has actually thought about this a little bit more than most of us. Adam Cheng, who does a lot of research and was involved in the ILCOR and guidelines process, a Canadian in Calgary, has actually looked a fair bit at this. And mannequins, there are some that are better than others. I think what we need to do, and recognizing that again, some are better than others right now, is I think we need to actually work with industry to tell them what our specifications are. What do we really need to help people to be able to do quality CPR so that they get that muscle memory, so that when they're doing it on a patient, they can actually be able to do that with good quality. We've talked to our colleagues here at Heart and Stroke Foundation of Canada, as well as our colleagues at the American Heart Association, and we're potentially going to approach industry to look at that and to say, look, we need better mannequins or more consistent mannequins that are able to do this. We know some exist now, but we want to have better ones for training and to use them consistently in our courses over the coming years.
Great, thank you very much. The next question is for Dr. Brooks. Dr. Brooks, are there any guidelines regarding the use of CPR devices such as Lucas 2?
Thanks for the question. So Lucas 2 is a mechanical CPR device. Lucas 2 is a piston device that has a suction cup on the end of the piston, so it does create compression and active decompression in its mechanism of chest compressions. And for the purposes of the ILCOR review, the committee decided to split the review into piston devices and load distributing band devices, because we felt that the mechanism of chest compression was different enough that we should examine the evidence separately. And ultimately, the recommendations came out looking almost identical in the two groups. The Lucas device was examined in a randomized controlled trial called the LINK study. And that is probably the highest level evidence that we have looking at the Lucas device. And there were some methods concerns with that studies. It was a randomized controlled trial of the device versus conventional manual chest compressions, but there were some co-interventions. So there were some other things that happened with implementation of the Lucas device that made it a little bit difficult to understand what the true effect of the device was. But in the end, this evidence was pooled with other evidence on piston devices, and the recommendation is, and I might be paraphrasing, essentially there wasn't a high enough level of evidence to say that mechanical devices should be used across the board for every cardiac arrest patient in every place, above and beyond or as an alternative to conventional manual compressions. However, the bulk of the evidence that we have on all mechanical devices basically didn't show a difference between manual and mechanical, or in one particular circumstance, there was a demonstration of equivalence between the two techniques with respect to outcomes. So the guidelines reflect that, saying that we cannot recommend routine use. However, for systems or hospital departments that have maybe optimized their manual chest compressions, this is an option for them as an alternative to manual chest compressions. And especially the committee felt that this made a lot of sense in situations where manual chest compressions were either difficult to do at high quality. So for instance, in a hypothermia case where CPR is prolonged and providers get fatigued, in the cath lab where just the technical space issues of providing manual compressions might be difficult, or importantly in a moving ambulance when providing manual chest compressions might pose a risk to providers. So the committee felt that it's a reasonable alternative, especially in those type of situations.
Great, thank you. We have one last question. I think after that will be concluding question period. Ms. Jensen, this question's for you. Can first responders, firefighters, police, and so on apply collars, or should they just use hold C-spine and await paramedics?
Thank you. Great question, and probably one that deserves further clarification. The evidence review that was done for ILCOR in regards to spinal motion restriction was specific to cervical spine immobilization or motion restriction. So the use of C-collars and other various things, soft collars, sandbags, various things like this. Many, many small studies were reviewed, and across all of these, there appears to be that there may be more harm than there is benefit from the general application of C-spine collars and similar types of devices. So the recommendation is that first aid providers hold the person still or coach the person, if they're listening, are able to listen to commands and cooperate, to remain still for that spinal motion restriction. Now, that being said, these guidelines will be reviewed by the Canadian First Aid Task Force and interpreted for specific groups within Canada, such as Ski Patrol and Life Saving Society and things such as this. So it may have a little bit more fine-tuning, but the recommendation is that these people should be held in a position with minimal movement of the C-spine and await EMS arrival. Thank you.
That's all the time we have for questions. If you have any further questions, please send them in to gl2015@hsf.ca. I now like to introduce Tony Conley, the Heart and Stroke Foundation of Canada's Director of Science and Education, for closing remarks. Tony?
Thank you, David. Many of you may be anxious to get updated right away. We're in the process right now of setting up systems that will allow you to complete your guidelines update. We will keep Heart and Stroke Foundation instructors updated as soon as the work is completed. Good news, the English ECC handbook will be the first English heart and stroke training resource to be launched simultaneously with the AHA's publication. What's unique about this particular publication is the Canadian edition is highly localized for Canadian clinical practice, including medications and dosages. The book will be available for sale next week from our heart shop and the Heart and Stroke Foundation's online e-store. Visit the Heart Shop by logging on to the Heart and Stroke Foundation Resuscitation website, and you'll find that on resuscitation.heartandstroke.ca. Instructors should watch their email for information on the instructor update process today, October 15th, and on October the 30th. Then we will provide more details for you. As David noted, this webcast will be available in the next few hours for you to use. I do encourage you to use this to spread the word of the guidelines within your own organisations and your own staff. All the questions that you've been posing over the last few minutes that we've not been able to answer at this particular time, we will be adding them to our frequently asked questions document. Please visit our guidelines website for the FAQs and for more information on guidelines and the science. The address will be on the screen shortly. Important to note, until instructors have completed their guideline update to be available on November 27th and have Heart and Stroke approved interim training materials to use in the delivery of updated courses, it is very important that you continue to teach the current 2010 guidelines. Please remember that the guidelines you are using currently are still acceptable and safe. The Heart and Stroke Foundation will be providing interim training materials to support the Heart and Stroke Foundation instructors in the implementation of the new 2015 guideline while using the current 2010 materials. A communication to the Heart and Stroke Foundation network will inform instructors of the arrangements for updating and receiving interim materials. We are excited to announce that the Heart and Stroke Foundation, together with the Canadian Red Cross, will be holding the first ever Canadian Emergency Care Conference on February the 22nd to the 24th, 2016 in Toronto. This will be your opportunity to hear more information from the experts from around the world on the science and guidelines on resuscitation and first aid, and network with colleagues from across Canada. Watch the screen for the website address for this conference. Registration is now open and it's filling up pretty quick. If you're not currently a Heart and Stroke Foundation instructor, please contact your own training agency for details on how you will be updated. Thank you to our speakers, Dr. Andrew Travers, Jan Jensen, Dr. Stephen Brooks, Dr. Alan DeCon, Dr. Michelle Welsford, Dr. Farhan Banji and to David Sculthorpe for hosting this webcast. I would also like to thank the many subject matter experts and scientists that represent the Heart and Stroke Foundation on ILCOR and on the science review and material review teams. Thank you all for your participation, great questions, and have a great day.